Okay, so good morning once again. Dr. Anne, let's make her the co-host so she can also be able to share your slide. Okay, so well, welcome to today's edition of YOF webinar discussion. We'll be discussing a very special topic today. It's not something that we commonly see, and it's not something that it's commonly discussed, and that will be eyelid tumors. So we have Dr. Anne here, who will take us through eyelid tumors and how to manage one of them, especially basal cell carcinoma. Dr. Anne, can you hear me?
Oh, please, I didn't realize I was muted. Okay.
Okay,
So, Dr.
all
Lee,
right.
can you hear me?
Yes, I can hear you loud and clear.
Okay,
So you're welcome. You can go ahead, share your slides, and then we'll start immediately.
Okay, I'm sharing now. I don't know if you can see them.
We can't see. I can't see from my hand yet.
I can't see it too.
Okay.
And I think her network is not stable. We lost her again.
Hello, Dr. Lee, I'm trying to share the slides.
Okay, no problem. We're with you. Yes, we can hear you. All right, so you can start now. Thank you very much for your patience, everyone.
Thank you so much. I'm very sorry once more. So good morning, my consultants, senior registrars, and everyone present. I would be presenting the topic classification of eyelid tumors and the management of basal cell carcinoma. Okay, so next slide, please. Next slide, please. So this is I'll be going by this outline: an introduction, epidemiology of eyelid tumors, anatomy of the eyelids, classification of eyelid tumors, and then management of basal cell carcinoma. Okay, so by way of introduction, the eyelid comprises a thin fold of skin that covers and protects the eye. With the exception of the prepuce and labia minora, the eyelid contains the thinnest skin. Eyelid tumors describe tumors that occur in or on the lid, and they are mostly epithelial in origin. Now, eyelid tumors account for 5 to 10% of all skin cancers. Most are benign, about 80%. The remaining 20% are malignant. Eyelid tumors have a female predilection and are more predominant in whites. The most common eyelid tumor worldwide is basal cell carcinoma. So moving on to the anatomy of the eyelids, it is a mobile multilamellar structure that covers the globe anteriorly. It features a row of upper and lower eyelashes, as shown in the diagram. So next slide, please. So the eyelid has some distinct layers. So from beginning from the most superficial, it has the skin and the subcutaneous areolar tissue, as shown in the diagram. Beneath that is the striated muscle layer, as the orbicularis oculi muscle. Then we have the orbital septum and orbital fat, then the non-striated muscle layer, then the structures that make up the posterior lamella, the tarsus, and the conjunctiva. Now, so the skin of the eyelid can be divided into the superficial part, which is the dermis, and the deeper part, which is the epidermis, and the adnexial structures. So the epidermis is composed of 4 layers of keratin-producing cells. It also contains melanocytes, Langerhans cells, and Merkel cells. The 4 layers of the epidermis are, the most superficial is the stratum corneum, and underneath that is the stratum granulosum, or the granular cell layer. Then the thickest portion is the stratum spinosum, which is also known as the prickle cell layer, and the layer most close to the dermis is the stratum basalis. Then the thicker part of the epidermis, the thicker part of the skin is the epidermis, which is composed of connective tissues, blood vessels, lymphatics, and nerves. The eyelid adnexia are the oil glands, the sweat glands, and the pilosebaceous glands, and the hair follicles. So these are diagrams showing the layers of the eyelid. From the diagram on the left, you can see the superficial epidermal layer, and then the thicker deep dermal layer, which contains the, I hope the diagram is clear enough. You can see the hair follicles and the sebaceous glands, and then the sweat glands. There are various types, the eccrine sweat glands that open directly into the surface of the skin, then the apocrine sweat glands that open into large follicles. The diagram on the right is showing the glands of mole and the glands of Zeiss in the eyelid. Okay, so about the blood supply of the eyelids. The upper eyelid, the blood supply comes from the internal carotid artery via the ophthalmic artery, and supplies the eyelid via the superior marginal arcade. The lower eyelid gets its own blood supply from the external carotid artery via the facial artery through the angular artery, and then it forms the inferior marginal arcade. The veins accompany the arteries and drain into the internal carotid vein, the external carotid vein, and then the cavernous sinus. Now, so the lymphatic drainage of the eyelid, majority of the upper eyelid and the outer half of the lower eyelid drains into the preauricular nodes, as shown in the picture. Then the upper medial 1/3 and the medial half of the lower eyelids drain into the submandibular group of nodes. So the key functions of the eyelid include: they serve as a major protective cover for the globe. They spread tears and other secretions on the eye and ensure the cornea is kept moist at all times. They also provide the blink reflex that protects the eyes from foreign bodies. The eyelashes serve to heighten the protection of the eye from dust, foreign debris, and perspiration. So now moving on to the classification of eyelid tumors. Eyelid tumors can be classified based on whether the lesion is a benign one, a pre-malignant lesion, or a malignant lesion. Now, so tumors can arise from any component of the eyelid, such as the skin, the glands, the vessels, nerves, and soft tissues. Hence, eyelid tumors can be further classified based on the composed tissue or cell of origin as epithelial, cystic, melanocytic, vascular, neural, hair follicle tumors, and then the lymphoid tumors. So the next slide here is showing a table which encompasses the tissues of origin and then whether the lesion is benign, pre-malignant, or malignant. So the cystic tumors, are usually benign. So we have the eccrine hydrocystoma, then the apocrine hydrocystoma, we have the sebaceous cyst, and then the epidermal inclusion cyst. The eccrine hydrocystoma are cystic tumors of the sweat glands, and they are caused by blockage of the eccrine sweat duct. The apocrine hydrocystoma is cystic lesion of the apocrine sweat glands, while the sebaceous cyst are caused by blockage of the sebaceous duct. Then the epidermal inclusion cyst is caused by implantation of the epidermis into the dermis, usually following trauma or surgery. So the epithelial lesions, which are the most common origin of eyelid tumors. The benign epithelial lesions are squamous papilloma, seborrheic keratosis, and inverted follicular keratosis. A squamous papilloma arises from the stratified squamous epithelium of the skin, while seborrheic keratosis is a benign lesion arising from the basal epithelium. The inverted follicular keratosis is thickening of the keratin layer around a hair follicle, and this thickening can be so great that it can form a cutaneous horn. Moving on to the epithelial tumors, the pre-malignant epithelial tumors, we have xeroderma pigmentosum, Bowen's disease, keratoacanthoma, and an actinic keratosis. Bowen's xeroderma pigmentosum is an inherited syndrome with features that predisposes a patient to developing basal cell carcinoma. So Bowen's disease, on the other hand, is also called a squamous cell carcinoma in situ. It is associated with human papillomavirus infection. Keratoacanthoma results from thickening of the prickle cell layer of the dermis, while actinic keratosis, these lesions arise from thickening of the keratin layer. So the two malignant epithelial lesions are basal cell carcinoma and squamous cell carcinoma. So the sebaceous gland tumors, the benign one is the sebaceous adenoma, which is a mild hyperplasia of cells in the sebaceous gland. There's usually no malignant change. Then the sebaceous nevus is hyperplasia of the nevus cells in the sebaceous gland, which in some cases begin to show some atypical changes. Then sebaceous carcinoma is a full-blown malignant lesion of the sebaceous gland. Then meibomian gland tumors, okay, it's actually a cyst, chalazion and hordeolum. And the sweat gland tumors are syringoma. The benign sweat gland tumors are syringoma and eccrine hydroadenoma. The syringoma is a benign proliferation arising from the eccrine duct, while eccrine hydroadenoma is a benign lesion of the eccrine sweat glands arising from the glandular epithelium that line the eccrine sweat gland. So the malignant sweat gland adenoma is adenocarcinoma of the sweat glands. So the hair follicle lesions are usually benign. They are trichoepithelioma, trichofolliculoma, and tricholemoma. Some texts use these words interchangeably. A trichoepithelioma originates from the epithelial cells of the hair follicle. A trichofolliculoma resembles a trichoepithelioma. It's just that it also involves the sweat glands and sebaceous glands around the hair follicle. So the tricholemal carcinoma is the malignant form of tricholemoma. Next slide, please. So moving on to the melanocytic lesions. The benign ones are melanocytic nevus and oculodermal melanosis. A melanocytic nevus results from a benign proliferation of the nevus cells, which are present in the epidermis. Then oculodermal melanosis is it results from an increase in the number of melanocytes in the uveal tissue and on the skin. This occurs in the dermal layer. So the premalignant melanocytic lesion is a lentigo maligna, which is a proliferation of atypical melanocytes within the epithelium. And the malignant variant is malignant melanoma. So the neural tumors are neurofibroma and schwannoma. Then the malignant neural tumor is Merkel cell carcinoma. Merkel cells lie close to nerve endings and receive sensation of touch within the epidermis. And the vascular tumors are capillary hemangioma, varix, and hemangioma. Hemangiomas result from proliferation of endothelial cells that line the blood vessels. When this proliferation occurs within the capillaries, it's called the capillary hemangioma. But when it occurs in other parts of the vessels, it's called a hemangioma. A varix is an abnormal dilatation of the veins or the lymphatic vessels within the dermis. So the malignant vascular tissues are Kaposi sarcoma and angiosarcoma. Then the histiocytic and fibrous lesions are xanthelasma, xanthogranuloma, and angiofibroma. Xanthelasma is should I say histiocyte laden with fats, with lipids, and these fats are usually intracellular. A xanthogranuloma is composed of is a histiocyte that is also laden with lipids and are composed of multinucleated giant cells. Then we have the lymphoid tumors. The benign one is a lymphoma. Next slide, please. Okay, so management of basal cell carcinoma. So basal cell carcinoma is the most common human malignancy worldwide. However, studies in sub-Saharan Africa show that squamous cell carcinoma takes predominance. 90% of cases occur in the head and neck region, and about 10% of these involve the eyelids. It is the most common malignant eyelid tumor, accounting for about 90%. The most important risk factors for development of basal cell carcinoma are older age, fair skin, and chronic exposure to sunlight. Okay, so as its name implies, basal cell carcinoma arises from the epithelial basal cells. So, okay, as I explained earlier, the epidermis of the skin has 4 layers of epithelial cells. The layer closest to the dermis is the basal cell layer, and that is where the basal cell carcinoma arises from, and that layer is a mitotically active layer. So basal cell carcinomas can develop from precursor lesions such as xeroderma pigmentosum. Also, a defect of the PTCH1 gene located on chromosome 9 have been associated with the development of basal cell carcinoma. That gene is also a precursor for the development of Gall's syndrome. Okay. So the management of basal cell carcinoma depend on a detailed history, ocular and systemic examination, investigations, and treatment. So for the history, the biodata is important because age is increasing age is a risk factor. Then the female gender is also a risk factor. Then the occupation, jobs with increased exposure to ultraviolet rays, such as farmers, are at greater risk. then tribe, persons with light skin, and then people of Scottish and Scandinavian ancestry, greater risk of developing basal cell carcinoma. Okay. So from the complaint is usually that of a lesion noticed on the lid. The lesion can be noticed by the patients themselves or other persons. So the lesion, basal cell carcinoma has a predilection for the lower eyelid, then followed by the medial canthus in 25%, the upper eyelid, 25% also, and then the lateral canthus. So the basal cell carcinoma, okay, then I would want to find out the course of the lesion. I want to find out if it is slow growing, if there's any increase in size, any change in color since it was first noticed, any associated ocular pain, redness, any history of recurrent eyelid swellings or eyelid infections. Okay, next slide, please. Then I would also want to inquire about history of chronic exposure to sunlight, history of immune suppression, any history of solid organ transplantation. And I also inquire about the history of exposure to radiation at any time, and then any past history of skin cancers or cancers in, or lesions on any other part of the body. And if the patient is young, the following should also be inquired about. Then that is taking into consideration now the inherited syndromes. For xeroderma pigmentosum, I would like to take a history of a dry, scaly skin in childhood. Then for Golin-Gall syndrome, I would also want to take a history of swellings or lesions on other parts of the body to rule out breast cancer or Hodgkin's lymphoma, which are the systemic tumors associated with Golin-Gall. Then for Muir-Torre syndrome, I want to inquire about any change in bowel habits, any diarrhea, constipation, blood in the stool, to rule out colorectal carcinoma or dysuria or hematuria, or even necroturia to rule out genitourinary carcinoma. Okay. So then for the history of complications, for invasion of the orbits and the sinuses, we want to ask if any history of reduced vision, double vision, protrusion of the eye, or associated history of spontaneous nosebleeds. Then for the care so far, I want to find out if the patient has had any previous treatments, any current medications. Then previous lid surgeries can also be inquired about. Then I want to inquire about the social history of the patient. Cigarette smoking is a risk factor for the development of basal cell carcinoma. Okay. So on examination, so of course, we begin with the visual acuity. It is done to assess the vision of the patient. Normally, basal cell carcinomas do not affect vision. So, but except when there is an orbital invasion, which is extremely rare. So the examination of the lids, I want to examine for any identifiable lesion. I will note the location, the appearance, the size, and the surrounding skin. And I also note the presence of ulcers, any crusting, bleeding, distortion of the lid architecture, signs of madarosis or telangiectasia. I also note, also palpate for any palpable induration. Okay, so clinically, eyelid basal cell carcinoma conforms to one of the following morphological patterns. It can be a superficial basal cell carcinoma, a nodular BCC, a nodulo-ulcerative type, or a sclerosing BCC. Okay, so first up is the superficial BCC, which appears clinically as a small flat area resembling normal skin. It may be mistaken for blepharitis and is usually not common on the eyelids. Superficial BCCs occur on other parts of the face of the head and neck. It's usually not so common on the eyelid. Then the nodular BCC, it presents as a firm, shiny, pearly nodule with small overlying dilated blood vessels, as shown in the picture. It's located on the lower lid. Then the nodular ulcerative BCC, in this form, the lesion has a central ulceration with pearly, rolled, and raised edges with dilated and irregular blood vessels, which are seen over the lateral margin. With time, the nodular ulcerative BCC may erode a large portion of the eyelid. So the tumor characteristically nibbles away the skin, like rodents, like where rodents nibble and bore holes into the ground. Hence its name, rodent ulcer. Okay, so the sclerosing form is less common and more aggressive, and it's usually difficult to diagnose because it infiltrates laterally beneath the epidermis as an indurated plaque. The lesions are difficult to delineate clinically and tend to be more extensive on palpation than on inspection. So we also want to assess the extraocular motility for any orbital infiltration. And this is very important for medial canthal lesions, as they are more likely to extend into the orbit. Then I would check the conjunctiva and the entire eye and globe for any abnormalities. Usually, basal cell carcinomas tend to be confined to the eyelid. So these structures are maybe essentially normal. Okay, so then the regional lymph nodes are palpated for metastasis. Basal cell carcinomas normally are non-metastasizing tumors. So when you see a lesion confined to the lid and then presence of regional lymph node involvement, we should raise a suspicion of other aggressive tumors, such as squamous cell carcinoma or sebaceous gland carcinoma. Okay. So for the investigations, we can carry out a hematological, radiological, and histopathological investigations. So for the hematological investigations, I want to do a full blood count, an ESR, and an electrolyte sedimentation rate, then if fasting blood sugar, retroviral screening, since for the full blood count, want to do the blood picture, want to see the blood picture, and then fasting blood sugar retroviral screen to rule out maybe conditions that can lower the patient's immunity. Then orbitocranial MRI, well, it may not be done in cases where the lesion is confined to the lower lid and you're sure clinically there's no evidence of extracranial or extraorbital extension. So this is reserved for patients with bizarre presentations to rule out what are eyelid malignancies that can resemble basal cell carcinoma. So next slide, please. Okay, so the diagnosis of basal cell carcinoma is histopathological, and biopsy of the lesion can be taken via an incisional biopsy or an excisional biopsy. Okay, so in incisional biopsy, only a part of the lesion is removed for histology. It's undertaken for tumors located on the medial canthal region or large tumors involving the lid margin. Excisional biopsy involves the surgical removal of the entire lesion and then tissue taken for histology. It is used when lesions are small and or for small lesions on the lid margin located away from the lateral canthus and away from the lacrimal punctum. Okay, so there are options for the coordination of histopathological diagnosis and tumor clearance with excision. The first is conventional paraffin embedded specimen and the standard frozen. Okay, can we go back to the previous slide, please? Previous slide. Can you take us back to the previous slide, please? Hello. Hello, sir. Hello, sir. I was still trying to discuss. Hello, sir. Okay, so all right, so we're there. Thank you so much. Okay, so there's the conventional paraffin embedded specimen, the standard frozen section, and the Morse micrographic surgery. For the conventional paraffin embedded specimen, it involves the use of formalin to fix the tissue before being conveyed to the histopathologist. It's used commonly in our environment because it is cost effective for the patient, but the disadvantage is it takes time before confirmatory results are retrieved. So the standard frozen section, this provides a faster confirmation of results, and it involves, it is done at the time of initial surgery. When the tissue is excised, it is passed to the histopathologist, who immediately freezes the tumor, the specimen, using a liquid nitrogen or carbon dioxide. Then the specimen is then sectioned and then studied under the microscope, and then the results relayed back to the surgeon immediately. So for the Morse micrographic surgery, okay, next slide, please. It's considered the gold standard for extensive basal cell carcinoma. The purpose of Morse surgery is to completely excise the lesion while preserving as much non-involved skin tissue as possible. It is used in cases that show high risk factors such as a sclerosing basal cell carcinoma, a recurrent tumor, or medial canthal location. So what is done in Morse micrographic surgery is the tissue is also examined frozen. The surgeon excises the tumor and then labels it, tags it, and then passes it on to the histopathologist. So for any part of the lesion that still shows malignant cells, the information is relayed to the surgeon, who then goes back to that particular area to take out a thin slice of the tissue, and then it is re-examined again, and then results are relayed back to the surgeon. And this process is repeated until tumor-free margins are reported. So in that way, we're able to excise the lesion completely and then preserve as much normal skin as we can. Okay, next slide, please. So the histopathology of basal cell carcinoma, the nodular and nodulo-ulcerative types, what the histological pattern is, it shows that the cells proliferate downwards. The cells are located in the epidermis. So when there's a malignant transformation, the cells proliferate downward into the dermis, then characteristically exhibit a palisading at the periphery of the tumor lobule, as shown in the diagram. They arrange themselves in clusters like a fence, forming circular lobules. Then the sclerosing or the morphic BCC, histologically, they show thin cords that radiate peripherally with islands of cells embedded in the dense fibrous stroma, as shown in the second picture. They don't exhibit the palisading orientation. So this slide is just showing a normal histological picture of a normal epidermis. So maybe when the histopathologist brings a result, since we know the normal and we know the abnormal, and what we are seeing from the histology is not correlating with what we have, we can ask him to please recheck. Okay, so next slide, please. So moving on to the treatments. Treatment options are surgical therapy, radiotherapy, cryotherapy, and medical therapy. Okay, so next slide, please. Next slide, please. So surgery is the treatment of choice for basal cell carcinoma. Surgical excision aims to remove the entire tumor with preservation of as much normal tissue as possible. Smaller tumors can be cured by excision of the tumor together with a 2 to 4 millimeter margin of clinically normal tissue. Larger and aggressive tumors require radical surgical excision, creating a wide defect, which may require lead reconstruction. Now, so the technique for reconstruction depends on the extent of the defect created. It is important to construct both the anterior and posterior lamella, each of which must be reconstructed with similar tissue. Anterior lamellar defects may be closed directly or with a local flap or skin graft. So the next slide is showing small defects, small defects involving less than 1/3 of the lid can be closed directly, provided the surrounding tissue is sufficiently elastic to allow approximation of cut edges. So, and if necessary, a lateral cantolysis can be performed for increased mobilization of skin. Then for moderate defects, okay, next slide, please. For moderate defects involving up to half of the eyelid, it may require a flap, that is the tensile semicircular flap for closure. So we can see in the picture on the left, the first picture is showing somewhat of a sclerosing basal cell carcinoma, which has been excised. Then you can see the marking, the tensile semicircular flap is marked. And then, okay, let's go to the next slide. I think I have, okay, so Saka, please, can you? Okay. So, yeah, so the surgeon has mapped out the tumor to be resected, and he's resecting, is creating a full thickness pentagon wedge excision. So the tumor has been excised now. And then it's been labeled. You can see superiorly we have the medial part of the tumor, and then the lower part is labeled lateral. So that is how it will be passed to the histopathologist. Okay, so he's trying to take measurements now to guide in reconstructing the, in suturing the defect. So he's making a semicircular incision to allow for mobilization of skin. Okay. So we can move on from here. Subsequently, you will just oppose the tissues. Okay, so large defects involving over half of the eyelid may be closed by one of the following techniques: the anterior lamellar reconstruction and the posterior lamellar reconstruction. Okay, next slide, please. So anterior lamellar reconstruction involves skin advancement, a local skin flap, or a free skin graft. The patient must be aware that grafted skin may not be a perfect match. So we can see a local skin a skin advancement and then skin graft. And the second picture on the right. Okay, so for posterior lamellar reconstruction involves use of upper lid pre-tarsal graft, buccal membrane graft, or a hard palate graft. Also, the heel tarsoconjunctival flap from the upper eyelid can be mobilized down to cover the defect in the lower eyelid, which is and it is left in place for 4 to 6 weeks before it is resected. So next slide, please. So, okay, so for the LASUTH approach, the full reconstruction of the defect created by the tumor removal may not always be required. In this approach, the wound edges are approximated as far as possible, and then the defect allowed to granulate and heal by secondary intention. And even large defects have been seen to achieve satisfactory outcome with time. Okay, next slide, please. So, about the treatment option radiotherapy. This is reserved for patients with extensive basal cell carcinoma with orbital invasion who are either unsuitable for surgery or refuse surgery. It is less preferred because the recurrence rate following irradiation alone is very high, and it does not allow for histological confirmation of the tumor, which is very, very important for eyelid tumors. For basal cell carcinoma, and is associated with radiotherapy is associated with many complications such as radiation-induced malignancy, obstruction of the lacrimal drainage system, cataract formation, radiation retinopathy. Okay, so next slide, please. So another option is cryotherapy. It may be considered for small superficial basal cell carcinomas. It can be a useful adjunct to surgery in some patients. It employs the use of liquid nitrogen. The complications associated with cryotherapy include skin depigmentation, madarosis, and conjunctival overgrowth. Okay. Next slide, please. So medical therapy. The topical medication, 5% imiquimod cream, has been shown to be effective for small superficial basal cell carcinomas. It is an immune response modifier, which acts by binding to toll-like receptors 7 and 8 on macrophages, monocytes, and dendritic cells, thereby inducing apoptosis and ultimately tumor regression. So various companies produce. Okay, so next slide, please. Then, so the newer medications which come in the oral form are the vismodegib and sonidegib. They are useful treatments for advanced orbital infiltrative basal cell carcinomas that is not amenable to surgical resection or radiation. The class of drug is a hedgehog pathway inhibitor. So what the drug does is it blocks the action of the protein responsible for tumor cell multiplication. So the hedgehog signaling pathway regulates the growth, differentiation, and proliferation of carcinogenic cells. In basal cell carcinoma, this pathway is upregulated. So inhibitors of the pathway are used to halt the proliferation of the cancer cells. And that's exactly what these medications try to do. But the adverse effects are, since they are taken orally, the compliance is usually poor, and side effects such as muscle spasm, alopecia, a change in taste, nausea, and diarrhea make patients not so compliant to the medication. The next slide, please. So the differential diagnosis of basal cell carcinoma, the benign differentials are actinic keratosis, shown in slide picture A. Then basal cell squamous papilloma showed in slide B, the pedunculated type. Then basal cell carcinomas can also mimic a chalazion, and then seborrheic keratosis. For actinic keratosis. Actinic keratosis, squamous papillomas, and seborrheic keratosis essentially have similar predisposing or risk factors as basal cell carcinoma. So these tumors can be differentiated on histology. Chalazion is usually located on the upper eyelid due to the presence of meibomian glands on the upper eyelids. We rarely have chalazions in the lower eyelid. So, and basal cell carcinoma, on the other hand, has occurs more in the lower eyelid. So these are some things that can help differentiate a basal cell carcinoma from a chalazion. So next slide, please. So the malignant differentials include squamous cell carcinoma, sebaceous gland carcinoma, a malignant melanoma, and a Merkel cell tumor. Squamous cell carcinoma and sebaceous gland carcinoma are really close malignant differentials of basal cell carcinoma. They clinically, most times they are clinically indistinguishable from each other, and that is why a histological confirmation is really important. So we don't resect a tumor thinking it's a basal cell carcinoma. Meanwhile, we're actually dealing with more aggressive tumors like a squamous cell carcinoma and a sebaceous gland carcinoma. Even a malignant melanoma, the picture depicted in C is a pigmented malignant melanoma. Some of the malignant melanomas may be non-pigmented and may resemble a basal cell carcinoma clinically, and they occur on the upper and the lower eyelid too. So a Merkel cell tumor can also be a differential of basal cell carcinoma, and the tumor it usually occurs on the upper eyelid and can be differentiated from a basal cell carcinoma after histology. Okay, so the prognosis is generally good for basal cell carcinomas as 5-year cure rates are up to 90%. Prognosis is worse with lesions greater than 3 centimeters, for long-standing lesions, and for deeply invasive tumors, and inadequate treatment too, and also poor prognosis. So in conclusion, basal cell carcinoma is the most common malignant eyelid tumor. It may be clinically indistinguishable from other eyelid tumors, so a high index of suspicion is required for diagnosis. Confirmatory diagnosis is histopathological, and early diagnosis and prompt treatment can provide cure. So these are my references. So thank you so much. Thank you so much. Thank you, Mas. Thank you, sirs.
Well, thank you very much, Dr. Ann. This has been a very in-depth presentation, well explained, and very detailed. Thank you so much, everyone, our teachers and senior colleagues and colleagues for listening. It's been a very refreshing presentation for me. I mean, I'm able to even learn new things as well. So we'll take comments, questions. Hello, can everyone hear me? Hope I'm audible.
Sure, you are very audible.
Okay, yeah. So we'll take questions and comments now. Thank you so much. Once again, Dr. Ann.
Thank you, sir.
I think there are some questions on the chat, but I can't see them anymore. I don't know if they're still there.
Oh, okay, questions. Let me check.
See some questions here.
I can't see any questions.
So we have a question from Dr. Oyeogo, who said, are there any follow-up measures or advice?
Yes, please. The patients can be advised to use sun protective measures, sunglasses, white ball hats, and some of them may be even advised to change some their occupation. So because to prevent a recurrence. So yeah, patients are usually followed up to ensure that there is no recurrence and the cure is achieved.
Thank you so much. So we have Dr. Bolanle Balogun has someone wants to make a comment. So Dr. Bolanle Balogun, please go ahead.
Thank you very much, Dr. Obi.
Thank
That
you, ma'am.
was quite impressive.
Thank you, ma'am.
I just want to put in a few comments. Based on the anatomical structure of the eyelid, it's important that we have a very wide range of diagnosis and knowledge base concerning eyelid tumors, because sometimes they can really be quite confusing, one resembling the other one. So it's very important that you are aware of that. And then in our own environment, we have major challenges in the sense that patients don't come early. So that then means we have to do more extensive procedures. And if we are faced with that, it's important that you also have a good grasp of the surgical maneuvers that you need to do for these patients. Good lead reconstruction is very important. Like she said, different procedures for different, depending on the extent of tumor. Early intervention, very, very important as well. So as much as possible, once you spot a patient whom you think this patient will have a malignant lesion, just go ahead, counsel the patient, and as much as possible, let that patient get on your next surgery list so that you don't lose that patient, because our patients tend to go from place to place seeking spiritual, all sorts of help, and eventually they come back with fungating lesion. So once we have that first chance with them, we should make the best of it. Follow-up is very important. Counseling is very important. Let them know that this tumor, well, I've done what I can do now, but let's keep tag of you. If possible, keep a personal record of this patient so that you can call them in from time to time to follow them up at least 5 years. Even some cases from our experiences with tumors, you find out that they say 5 years, okay. Sometimes these patients go and then they come back much later, even later than 5 years. So more or less keep tag on them for up to 10 years. I'll say that.
Okay.
Other challenges we have is issue of rehabilitation, particularly in the cases that have invaded the orbit. Now you have to do exenteration. We find it difficult to provide good rehabilitation for them. So we must try as much as possible to catch them early. Then in terms of diagnosis, if you are planning a MOS procedure, you must liaise with the pathologist ahead of time, not on the day of surgery, maybe 1 or 2 weeks ahead, so they can prepare and actually get ready for you. That's very important. You can't catch them overnight. They are not going to be there for you. So those are my few contributions. Thank you very much.
Thank you so much, ma'am. Thank you, ma'am.
Thank you very much, ma'am, for the additional contributions. I mean, coming from experience, we appreciate that. Thank you so much. So we have another few questions by Dr. Ume. She asked if there is need for imaging, such as CT scan.
Okay, so I would rather shy away from CT. So because we don't know what we are dealing with, you cannot tell that this is a basal cell carcinoma clinically. You can't make that diagnosis comfortably clinically. So if it's an extensive one, an aggressive one with orbital infiltration, yeah, you might want to do an MRI to be sure you're not dealing with a squamous cell carcinoma, because that's the one that has perineural spread and can spread to intracranial structures. So yeah, we can do a neuroimaging.
Please, can I chip in a bit here? In some of these tumors, by the time these patients come, like I said, our patients don't come early. So the high chance of orbital invasion is there. Much as you want to do an MRI, if you suspect squamous cell tumors, but we know that BCC is more frequent. And so you want to look at the bones. You want to be sure if this tumor has invaded the bone as well as the soft tissues. And CT is actually more cheaper for most patients. So you still need CT scan. Dr. Obi, from my experience in clinic, don't you forget that.
Yeah. Thank you so much, ma'am.
Thank you.
So thank you very much, Ma. We have other question here from Dr. Odera. Why do medial cancer lesions spread to the orbit? Maybe Dr. Ann, you can just expatiate more on that.
Okay, so yeah, the location of the medial canthus as some blood vessels and lymphatics. So the tumors can spread via these structures into the orbit, and also the lacrimal sac and the lacrimal drainage system is also part of the medial. It's in the medial wall of the orbit. So because of the lymphatic and the lymph vessels and the blood vessels in the medial canthus, the tumor spread via that route easily into the orbit.
Can I add a little more information? The medial canthus has, let me say, slightly not as thick as the other structures of the eyelid. The medial canthal area specifically does not have the tarsal plate. So it's much easier for a medial canthal tumor to invade because its next structure really is the orbit. There is actually no barrier which the tarsal plate offer in the other parts of the eyelid.
Thank you very much.
Thank you, ma'am.
Okay, so there's another question by Dr. Lasisi. She asked, what's the biggest fear with extensive eyelid basal cell carcinomas has been confirmed on histology since it doesn't really metastasize? And she further asked that why do we want to use the Morse micrographic surgery at the medial canthus? Because you mentioned earlier that we could do excision biopsies at the location. So maybe a little bit clarification from our teacher, Dr. Balogun, and also from the presenter.
Okay. So we would want to do a Morse micrographic surgery. The aim of the Morse micrographic surgery is to preserve tissue. So for medial canthal tendons, medial canthal lesions, we would want to take thin slices of the skin and examine in sections, so such that when we don't create a very wide defect and don't have to go to expose structures close to the lacrimal drainage system. Okay, so I don't know, Ma, please, you have a contribution.
Morse procedure is not necessarily for medial canthal lesions only. The primary goal really is you want to make sure that you don't leave malignant tumor cells behind, much as you also don't want to take too much of normal tissues. Because look at the eyelid, if you have to take too much of tissues off, That then means your surgical repair is going to be more expensive. I think she asked about 2 or 3 questions. I can't remember the first one now.
So the first one says, what's the biggest fear with confirmed, histologically confirmed extensive eyelid basal cell carcinoma?
Well, the biggest fear is extensive. So definitely this tumor may have invaded the orbit. That's one. The risk of having to do orbital exenteration, we worry about it because that means that patient is going to lose an eye. We're going to have cosmetic defect as well. And yes, those are the major risks you worry about. And if you don't achieve complete excision, the risk of recurrence is also there.
Thank you very much, ma. We have Dr. Therese, who also is interested in making comments. Dr. Therese, ma, please go ahead.
Okay. Thank you very much, Dr. Ann and the team. I have a comment. From the presentation, some risk factors were being female and being light-skinned. And in our environment now, in fact, a large population of female wants to be light-skinned. They're using all kinds of organic creams, bleaching cream, all of that. So I can imagine that will increase the risk factor. And besides that, following surgery, there's the possibility of wound breakdown and all of that. So I'm thinking this is something the oculoplastic team and possibly the public health team should pay attention to, like advising people on reasons why they should avoid such things, because I can imagine that it will increase the risk and it will worsen the outcomes after surgery. Thank you.
Thank you so much, ma.
Thank you very much, ma. I'm not sure, do we have more questions or comments from our experienced oculoplastic surgeons, and maybe 1 or 2 personal experiences that we can share, and then about the management of 2 more cases like this, especially basal cell carcinoma or any other related eyelid tumors. For me, while we're waiting, it's been a very enlightening discussion. And I hope every one of us, we've gained 1 or 2 from this presentation. I would hand over to the chairman, Dr. Bature, to make final comments, and then we can round up the presentation. Thank you.
Thank you so much, Dr. Idris. Dr. Ann, it was a very detailed, scholastic presentation. We really appreciate you. Thank you, Prof. Mark, for joining us today and the contributions towards understanding this topic better. We appreciate all WIOs for joining us, and we believe we're sharing knowledge together. We're building a community of young ophthalmologists that will future the training, provide clinical services in eye care in the country. So we appreciate everybody for coming. And also don't forget to fill up the Google form shared by the secretary some few days back on the group in terms of the membership data being compiled by the young ophthalmologists. Please, we need that data. It's very important for planning and also other logistics. Thank you so much. So we'll see you next time.
Okay. So thank you, sir. Thank you, everyone.
Bye.